Hello everyone, and welcome to the fourth and final video in this webinar series for the Minnesota Health Literacy Partnership's 2022 Health Literacy Month campaign. The previous webinar focused on plain language, which is clear communication that your audience can read or understand the first time they read or see it. In that webinar, we reviewed the history of plain language actions and initiatives in the United States since the 1970s. We also discussed how using plain language can help avoid confusing medical jargon and advance health equity. In this webinar, we'll be talking more about health equity. Specifically, we'll discuss what health equity means, as well as some examples of health inequities in the United States. Then we'll take a look at vulnerable populations that are at increased risk of adverse health outcomes and talk about how individuals, communities, organizations, and governments are working to advance and eventually achieve health equity. Let's begin by discussing what health equity is. Health equity means that every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving their full health potential because of social position or socially determined circumstances. Health equity is accomplished by removing unfair differences in health status or distribution of health resources that stem from the social environments in which people are born, grow, live, work, and play. The next slide features a few examples of unfair differences between demographic groups in the United States. There are countless examples of health inequities, which are also called health disparities, in the United States. Unfortunately, historically disadvantaged groups continue to experience poorer health outcomes compared to historically advantaged majority group individuals. Many individuals begin their lives at a significant disadvantage through no fault of their own. For instance, Black infants are 4 times as likely to die from low birth weight complications compared to white infants. Another minoritized and marginalized group, namely members of the LGBTQ community, is more than twice as likely as heterosexual individuals to have a mental health disorder during their lifetime. The final example here pertains to Latino adolescents, who have a higher obesity rate, 19%, compared to that of white adolescents, 12%, and Asian adolescents, 7%. We've already named a few vulnerable populations that experience worse health outcomes compared to other groups, but let's take this discussion further. In addition to the first 2 bullet points, which were discussed on the previous slide, other groups to consider in our discussion of health equity are people with disabilities, people with low income, people with limited English proficiency, and immigrants. I'll now take a moment to focus on each of these groups individually. Millions of people in the United States live with a disability. An estimated 1 in 4 U.S. adults has a disability, such as limited mobility, deafness, blindness, or an intellectual disability. According to the Centers for Disease Control and Prevention, commonly referred to as the CDC, people with disabilities have less access to health care, have more depression and anxiety, engage more often in risky health behaviors such as smoking, and are less physically active when compared to people without disabilities. People with low income, including those living in poverty, are at greater risk for numerous adverse health outcomes, such as shorter life expectancy and higher infant mortality rates. Compared to people with higher incomes, people with low incomes are less likely to have health insurance and have ready access to primary and specialty care. For people with low income, the cost of medical care is often unaffordable, leading to delayed or foregone medical care. As a result, health problems can long go unchecked and develop into serious or chronic health issues. According to the Journal of Medical Ethics, quote, patients with limited English proficiency are among the most vulnerable populations. They experience high rates of medical errors with worse clinical outcomes than English proficient patients and receive lower quality of care by other metrics. Two ways to combat these health inequities are 1, to provide language interpretation services, and 2, to deliver health information to patients at an 8th grade reading level or lower. The last vulnerable population listed here is immigrants. Many immigrants have limited English proficiency. In addition to language barriers, immigrants are more likely than non-immigrants to experience cultural barriers when seeking health care. For example, immigrants may refuse prescription medications, blood transfusions, surgeries, and other medical treatments due to cultural or religious beliefs. So, how can we advance and achieve health equity? This is by no means an exhaustive list, but it does summarize key efforts that individuals, communities, organizations, and governments are currently taking to reduce health disparities. The first action on the list is practicing cultural humility in medical and public health settings. Cultural humility means having a humble and respectful attitude toward people of other cultures. Adopting this attitude in medical and public health settings can help create a safer and more inclusive environment for all people. Improving collection of data on race, ethnicity, language, disability status, and sexual orientation and gender identity is another key step in advancing and achieving health equity. Tracking this kind of information can help identify where gaps in health outcomes exist between different population groups. It is essential that community members, leaders, and allies of disadvantaged and minoritized groups have a seat at the table when policy is being made. Including these individuals in the policy-making process helps to create policies that best serve their communities. Another way to create more inclusive environments and advance health equity is to provide services and resources in multiple languages tailored to the racial and ethnic groups in a population. For example, the state of Minnesota provides printable Medicaid application forms in English, Hmong, Russian, Somali, Spanish, and Vietnamese, languages that reflect the diversity of Minnesota's population. The final bullet point I've included here is to devote research funding to the investigation of health disparities. Health disparities research has grown and intensified in recent years, with numerous universities, government agencies, foundations, and private companies dedicating millions of dollars toward health equity-focused research projects and initiatives. This concludes the 4-part webinar series for the Minnesota Health Literacy Partnership's 2022 Health Literacy Month campaign. In these webinars, we've talked about 4 major themes: health literacy, past and present, plain language, the teach-back method, and health equity. Each of these slide presentations for the webinars are available for download on the Minnesota Health Literacy Partnership's website. In addition, be sure to check out the partnership's social media channels for weekly content during its upcoming Health Literacy Month campaign in October 2022. Thank you for tuning in, and I hope you enjoyed going back to the basics of health literacy.